radiologist, does a great deal of work in terms of neuroendocrine tumors, and he's from UBC, but he's done work in Chicago and Portland as well, and has some current work being done at UCLA. Without further delay.
Thank you very much. First and foremost, I'd like to thank the committee, in particular Colleen and Dr. Reed, for inviting me and having me out here. It's truly an honor. And secondly, I'd also like to congratulate you all for making this conference possible. It's very exciting to see a collaborative group of people all learning together and developing paradigms that are really going to affect therapies for the patient population and for the disease process as a whole. And of course, the final fact is that I have about 20 minutes to cover about 45 minutes worth of material, so I'm glad that you're all caffeinated, had some sugar, because you need to fasten your seatbelts because we're going to fly. So, what I'd like to do is just outline our discussion by talking about the rationale for local, regional, and intra-arterial therapy. In other words, why do we do this? What's the principle of therapy, and what are the mechanisms of action? We'll then go through the evolution and evidence base for the type of embolotherapeutic procedures that we have. First, of course, we start with bland embolization, which is essentially blocking a blood vessel with a particle. Then with chemoembolization, which is kind of a catch-all term for lipoyl-based or oily-based embolization, of which is also going under its new phase of evolution. And finally, cover what's termed radioembolization or yttrium-90 microparticle embolization. We'll then, if we do have the time, cover some intraprocedural management issues and just summarize a few comments. So setting the stage for intra-arterial therapy, we know that both primary resection as well as cytoreduction can cause an improvement in quality of life as well as overall survival. In other words, we know that if we have 10 cancerous or carcinoid cells and we're able to take 8 of them away and leave 2 behind, we can improve quality of life, we can improve overall survival, and we're doing something good. We're not just doing it for the sake of doing it. And that's, of course, extrapolated by those cases where we've discussed already about palliative tumor debulking. We also know that palliative tumor debulking through a myriad of literature from the early and late 90s has proven to not only improve symptoms but also improve overall survival benefit. So the conventional wisdom, as you probably come across, of course, I wouldn't necessarily put us in that company or in that category, but the conventional traditional wisdom for treatment of neuroendocrine disease and neuroendocrine tumors is that it does have an indolent growth rate. It grows very, very slowly. Only treating when quality of life becomes an issue or when it becomes life-threatening has always been the general philosophy, the ethos behind therapy. And there's little consideration for the contribution of overall survival because as our mantra is, if you don't suspect it, you can't detect it. But by the same token, I think the third point is you can't treat it. So very many people do present later on in their disease processes, and therefore the starting point of therapy and measurement of overall survival can be somewhat of a challenge. Traditionally, the procedures that we have been doing have been very invasive or potentially toxic, including surgical resection, external beam radiation, some forms of chemoembolization, and even some forms of ablative therapies like radiofrequency ablation and cryoablation. So just as a brief sideline, I'd just like to touch very briefly on percutaneous and intraoperative ablative therapies, namely radiofrequency ablation and cryoablation. In summary, we know from Berber's work out in a Cleveland clinic that we may not be able to provide curative intent in radiofrequency ablation, but tumor debulking does improve quality of life and has similar results to a very robust group of data sets that have been developed from percutaneous ablative therapies for hepatocellular carcinoma, which is a unique type of cancer within the liver. And we can provide symptomatic relief of that. Cryoablation, there's very little published data. Earlier experiences were intraoperative and encountered several types of complications which have now been ameliorated with better technology cryoablative techniques. But from an evidence-based perspective, nothing has really been shown to be of benefit. That's not to say that's detrimental, but just that it's not beneficial. So within the context of ablative therapies, these are best suited for either lung lesions or morphologically compatible oligometastatic liver disease. In other words, tumors that are of the correct shape and that are generally less than 3 in number, or during intraoperative primary resection. So let's go through very quickly the rationale for an endovascular approach. This includes I-131 labeled Lipiodol. This includes bland embolization, chemoembolization, and radioembolization, and of course the new generation of doxorubicin drug-eluting beads. This is a micrograph, or actually this is a staining, a casting of a rat tumor sarcoma, and it really illustrates very nicely what happens to a tumor. What we have is the main blood supply of a normal vessel, and you see this crosshatch pattern of what the normal capillary flow is. As we enter into the tumor, you can see that not only the density but the appearance of the blood vessels become quite abnormal. Density is increased, the blood vessels are abnormal, and centrally you almost see this depression or this black area in the middle, and that's an area of necrosis. So fundamentally speaking, we have disorganized blood vessels morphologically around the tumor itself. That's actually what we're trying to target, and whether we're targeting it through chemotherapies, whether we're targeting it through radioembolization, whether we're targeting it through through peptide labeling, that's really what we're trying to get. So in terms of vascular embolization, the pros include an increased local regional exposure. In other words, whatever we inject will be at a higher concentration to the targeted area than outside. Therefore, we can increase the amount of chemotherapy while decreasing the amount of toxicity. We can increase the amount of radiation while decreasing the amount of radiation exposure to the normal liver parenchyma. We also potentially decrease the toxicity of whatever chemotherapeutic we give because it's targeted through the blood vessel, not through the intravenous blood supply, but through the arterial supply. Terminology such as Cmax, or maximum concentrations, and AUC, or area under the curve, is significantly decreased in systemic exposure for chemotherapy. Therefore, we can increase the concentration, decrease the toxicity, and potentially increase the efficacy of the therapy that we provide. In addition, with embolic procedures, we may also be able to complement percutaneous thermal ablative procedures because one of the biggest issues is with that dense blood supply, there's a lot of blood flowing in and a lot of blood flowing out. And the principles of ablative technologies like cryoablation, radiofrequency ablation, and microwave ablation are all based on the generation of heat. So you can imagine if you have the tumor is a radiator, and if you can block the blood supply in the radiator, it can increase the efficacy of the thermal ablative zone. Now, the cons of ablative therapy are many, and some of them are theoretical, some of them are practical. One is that if we don't really truly become embolic, in other words, if we don't block the blood supply off, we'll have increased upregulation of VEGF and HIF-1, or hypoxia-induced factor 1. These are both angiogenesis switches. In other words, it can increase the aggressivity of the tumor. So we have to try and complement our embolization with something else, give it a double hit, so to speak. The restriction in cell stress may cause increased aggressivity and growth, and this has been shown in a number of animal models as well as within a number of liver tumor models. There is a direct relationship to anatomical necrosis of the gallbladder and pancreas within embolotherapeutics. In other words, it's not just giving a specific dose, it's giving a specific dose within the correct blood vessel at the right time and knowing when to stop. Because if you over-embolize, whatever you give, whatever therapeutic, it's not that smart, it will go to whichever second-order blood vessel, which could be the bowel, which could be the pancreas, which could be the gallbladder. Not to scare you, but these are the things that we're very cognizant of when we look at targeted and local regional intraarterial therapy. So in terms of the microenvironment itself, we can approach treatment of a tumor in several different ways. So this is just a schematic of the arterial blood supply, just a normal blood vessel. This is one of the smaller arterioles. And as we break down into smaller and smaller capillaries, we reach into the aberrant vascular plexus. So what we can do is we can affect the tumor microenvironment and microvasculature by using the inflow of vessels and vasculature through such techniques as embolization, or by using biologic class chemotherapeutics. Prime example is Avastin or bevacizumab. You've also heard of Sutent, which is obviously in phase 3 trials looking at pancreatic islet cell tumors. You can affect tumor architecture either by thermal ablation, in other words, by using a radiofrequency ablation probe, or radioablation, either by using targeted neuropeptides or by using microspheres that target into the tumor using its own vascular supply. So ultimately, what we have to do is in those situations, find the right particle for the right place. In other words, we want to target in the right area. Of course, from a systemic point of view, we can look at cellular respiration and metabolism, and those are the tyrosine kinase and multikinase inhibitor class chemotherapeutics which have now come online. One of the most common ones, of course, as you may have heard, is sorafenib or Nexavar, but there are a number coming down the pipe as well, and also hexokinase 2 inhibitors such as 3-bromopyruvate, which is currently under investigation in phase 1 trials. You can also affect DNA function, which is what we consider traditional chemotherapy and what we generally use in chemoembolization. So within hepatic arterial embolization, we have a collective data set, and this is not meant to be a comprehensive review, but just a representation of the largest data sets. And you can see that the experience has varied from the early 90s to even present day. And ultimately, what I'd like to draw your attention to is radiographic response and symptomatic relief. Unfortunately, as we were alluding to, the aspect of measurement of overall survival or median overall survival as an outcome measure based on single institutional studies becomes very difficult because, as you're all familiar with and as you've been to many institutions, there's a variation as to when to treat, how to treat. That's what ultimately the challenge is. We're aggregating data that may not be able to be aggregated collectively, at least within the intraarterial embolic realm. So if you just take a thumbnail sketch of radiographic response, what we vary is somewhere between 50% to 90%, and symptomatic relief between 50 to 80%. Median survival, quite frankly, it doesn't really apply when you look at these data sets. But here's a representation of the particles that we're looking at. Different particles, different shapes, different blood vessels. So chemoembolization was the next generation. That was the usage of lipidol-based carrier, in other words, using an oil as a carrier to be able to deliver chemotherapeutics. Well, what's the protocol? What you can do is you can take a hodgepodge of any of 1 to 3 of these chemotherapies, mix them with a hodgepodge of 1, maybe 2 of these embolics, and that's what collectively was referred to as chemoembolization. So when you look at the chemoembolization data, it's very important to look at the embolic that's being used and the chemotherapy. Unfortunately, in very many of the neuroendocrine published papers looking strictly at traditional lipidol-based chemoembolization, they do not mention what embolic they use. They don't mention their endpoints, nor do they mention the type of chemotherapy they use, and that's the challenge. So once again, we're actually just going to step it up a notch because I think I have less than 5 minutes to cover probably about 15 slides. So bottom line is radiographic response varies from 50 to about 90%, exactly what we expect. Symptomatic relief, slightly better. So then the question becomes, well, is chemoembolization as a technique better than hepatic arterial embolization? And this question was addressed in an article in 2007 looking retrospectively at 67 patients who were randomized to hepatic arterial embolization and chemoembolization, looking at complication rate and also other surrogate measures like time to progression and overall survival. Bottom line was that there was no statistical significance demonstrated, and the problem was the power of the study. In other words, there weren't enough patients enrolled in the study to be able to give a proper statistical analysis. But what we can see from the trends demonstrated was that 5-year survival was 33% versus 50% in randomized match control population, 2 different institutions, in bland embolization versus chemoembolization. Symptomatic relief was much longer for chemoembolization as opposed to bland embolization. So we're kind of forming this mold, this jello mold. The chemoembolization, in other words, a double-hit therapy, an embolic procedure with some sort of therapy actually provides benefit. So we're going to go in the Wayback Machine for a moment because I think that we really do have to acknowledge the work of Dr. Warner back in 1968, who described one of the first yttrium-90 microsphere radioembolization procedures. So this is not a new technology. This has been well thought out. It's just that the evolution of therapy really took until about 2004 before regulatory approval and a consistent manufacturing methodology was obtained. Concurrently, there's also a lipidol labeled 131, and these are considered the 2 types of radioembolics which really are at the forefront of therapy for hepatic metastatic disease. So yttrium-90, I won't get into the details. I'll just show the slide so that when you go online you can look at the slide, and we'll just skip that. And we'll just cover really quickly the principles of external beam radiation versus internalized radiation, which also can also cover a neuropeptide coverage. So illustrated here is a tumor in yellow, and these little kind of star-like objects are representative of the radiation. In simple conventional external beam radiation, what we do is we create a path of radiation through the tumor itself. And then we overlap them with different vectors so that mathematically there's an increased amount of radiation within the tumor itself. But the issue is that all the other cells on the outside, including the gastric mucosa, including the pancreas, including the stomach, are also exposed. And the normal liver parenchyma is also exposed. And all of these are very radiosensitive. In other words, too much radiation within these areas can cause failure. And unfortunately, that's what happens with external beam radiation, conventional external beam radiation. Some would argue with IMRT, or intensely modulated radiotherapy. Now, with selective internal radiation, or SIRT, which is the Y90 microspheres, and you can also apply this to the neuropeptide-labeled analogs, what we do is in the case of selective internal radiation, we actually inject the particles directly into the vascular plexus, the blood supply of the tumor. So as opposed to having radiation come in from the outside, it actually emits from the inside and causes coalescing isodose clouds, which then create the ablative zone. has a mean free path of 2.5 millimeters, so a very, very small area is treated, has variable energy, and has a cumulative effect of over 2 weeks. As you're all familiar, the half-life is about 64.2 hours, which basically means 7 half-life decay is 7 weeks. So we actually have a sustained low-dose radiation. This is not the same principle as external beam radiation. So I'll show these slides and just basically summarize them very quickly. Essentially, this was a study that we did in conjunction, 10 sites. We all collaborated on it. Just looking at overall dose and overall survival, we can see median survival was 70+ months, which is actually quite good compared to historical data. But as I was alluding to, median survival is somewhat of a surrogate measure because of all the challenges that we have dealing with neuroendocrine disease. Radiographic response was demonstrated, and I'll show you in a summary slide, radiographic response was demonstrated to be excellent. This study was looking at both types of radioembolic spheres, the SIR spheres and TheraSpheres, basically demonstrating that although the median survival had a statistic variation, it had to do with enrollment within each site and institution. But bottom line is that both demonstrated similar efficacy and similar RECIST-based response, as well as EASL-based response, which is the alternative methodology for determining objective response based on CT scan or tumor morphology. And this was the most recent article published in Cancer from the St. George's Group in London, looking at radioembolization and demonstrating the prognosticators of those patients. In other words, which ones do better and which ones do worse. And I'll summarize all this later on. I just want to leave the slide up so that if you do log on and take a look at the studies, you can have the reference and the material available. So in summary, what we have is a data set looking at radiographic response, overall survival, and symptomatic relief. And you can see that the degree of radiographic response was also highly variable. Survival, as I said, is kind of irrelevant within the context of these studies. And the bottom line is whether you use resin, which is the SIR spheres, or glass/ceramic, which is the TheraSphere, they both work equally as well. There are fundamental differences between the two. The resin spheres, the SIR spheres, have a higher embolic load because per sphere the radioactivity is less, so therefore it has a higher degree of blockade of the blood vessels and may potentially have a higher degree of complication as a result of that. But as we can see from the original data, as we follow through the evolution from bland embolization to chemoembolization, we know that embolization works in its own right. And what we want to do is we want to try and complement the embolization with the radiotherapy. Special cases of embolotherapy, we know that we can do chemoembolization multiple times. We know that we can do radioembolization after chemoembolization if there's radiographic evidence of progressive disease. And we also know that by doing these therapies, we can increase quality of life. One thing that's worth mentioning, though, and that isn't really mentioned in a lot of this literature is the recovery time after chemoembolization versus after bland embolization versus after radioembolization. Typically, yttrium-90 microparticle radioembolization patients are discharged on the same day or the next day. Chemoembolization patients, if any of you in the audience have experienced a cisplatin-based thiodol or Lipiodol-based chemoembolization, may result in hospitalization for 3 to 5 days, and it may result in just kind of feeling a little down and a little cruddy for the next month or so. But it's highly variable between individuals. Special considerations. I'm actually just going to fly through these slides. I'm not even going to comment on them because of the interest in time. But essentially, there are special considerations that one has to make while doing these procedures because they are not done under general anesthesia. They're done under moderate sedation. And therefore, what we need to do is be very careful about how we pre-treat and optimize each individual person. It has to be an individualized effort. Otherwise, we end up with instructions like take 2 of these before you go to bed, or take 2 of these just before you go to bed and 2 just before you wake up. So some very brief examples. A gentleman with neuroendocrine, or actually carcinoid metastases of unknown origin, pre-radioembolization with yttrium-90 microparticles, post-radioembolization 1 year later. Another example, coronal section arterial phase. This is part of the triple phase series CT, demonstrating the liver here, this little triangular structure. Tumors here, all very dense in contrast, which means they're highly vascular. Post-therapy, 3 months, you can see a hyperemic rim, which is a normal finding. So basically devascularized. By EASL criteria, which is one type of grading system, that's a 100% response. Another example, this was an individual who was a special circumstance, was also diagnosed with NASH, which was a type of liver disease or fibrosis, non-alcoholic steatohepatitis, but had a hypervascular lesion, as you can see right here on the coronal section. Post-therapy, uniform hyperemic rim, a very good response. So this is probably the most important slide. These are the take-homes, the FAQs, the frequently asked questions. Which is better, Y90 chemoembolization, or bland embolization? Well, the bottom line is, as we were alluding to, looking at median overall survival as a measure of outcome may not necessarily be the best tool that we have. If we take the assumption based on the surgical literature that cytoreduction does increase overall survival, then we can actually use time to progression and progressive-free survival as surrogates and direct measures, and therefore our data set will be a little bit more robust as opposed to this aggregate pool of data based on patients' entry criteria, which may be variable from institution to institution. There's less downtime with bland embolization and with radioembolization. In other words, the whole concept of the post-embolization syndrome doesn't reach the same severity. According to standard SAE or severe adverse effect outcome measurements, generally with radioembolization and bland embolization, we don't go above about a grade 2. With chemoembolization, we very routinely go to a grade 3. Chemoembolization is confusing, as we talked about. There are a number of different techniques for chemoembolization, so it's very important to be educated as to a specific technique that's being used. When to treat? Sooner better than later. Symptomology should not necessarily be the only criteria for when to treat. And an important take-home is that this is not a competitive type therapy. In fact, it may be complementary to targeted peptide therapy in locally progressive disease. So, for instance, if you have a very large tumor burden within the liver and also the presence of extrahepatic disease, it may be worthwhile to complement by treating the liver and increasing the distribution of the neuropeptide to the non-liver portions, in other words, the non-arterial supply portions, to be able to increase the local regional exposure and dose response while potentially decreasing the toxicities available. When to retreat, radiographic progression may be a consideration. Surgical optimization, in other words, if we found a way that can take out the metastatic disease, that's potentially an indication. And also, of course, return of symptomology, because palliation, comfort, quality of life are also very important measures as to what we do. Prognosticators of survival and potential complications. This is an aggregate of the King data, some of the data that we published at Northwestern, as well as some of the aggregate data that I demonstrated on some of those slides. If there's an increased tumor burden, that puts you at obviously greater risk. If liver function is tenuous, we could potentially throw the baby out with the bathwater, so to speak, by treating the normal liver and causing problems with the normal liver as opposed to just treating the tumor. And the presence of extrahepatic disease with embolotherapy as a standalone therapy. Performance status. How do you feel before you go in? If how you feel before you go in is crappy as a result of the symptomology you have from the disease process, we may be able to reverse it. However, if there is just a general malaise as a result of fulminant progressive extrahepatic disease, that may be an indication that we may be doing less for you by doing something. In other words, the fundamental difference between doing something to you and something for you lies very true in that situation. Previous hepatobiliary surgery, if you've had a pancreatic duodectomy as a result of pancreatic islet cell, well, then we have to be very aggressive with treatment of bowel preparation and antibiotics, because the incidence of myeloma and liver abscess increases by 4. Which can be a real problem. And if you've had a papilloma before for a gallstone, that's also a consideration. We have to know in order to optimize the type of therapy for you. It's not impossible, but it's just something that we need to actualize. And of course, as we've heard over the last 2 days, measurements of response is also a very important benchmark. In other words, if you don't know where the race started and where it ends, or you don't have an objective measure of what degree of tumor burden or what quality of life measure or what your intent for treatment is, then it kind of defeats the purpose of doing something. In other words, we're doing it to you and we're not doing it for you. The techniques really haven't been perfected yet. In other words, we don't know whether we want to be more embolic or less embolic. The literature, trends towards a higher embolic rate, more radioactive or less radioactive. We haven't really figured out what the correct radioactive dose is, but from a local regional standpoint, we're giving very, very large doses to the tumor. It's not very happy. It basically gets destroyed from the radiation that we provide. And in terms of chemotherapy or chemoembolization, we still don't know what the correct chemotherapeutic is or what the correct dose is. And those are the complex factors that we always have to take into consideration when we're talking about intraarterial embolotherapeutics. So thank you for your time, and thank you for staying awake.
Thank you, David. That was a very excellent talk. Now,